I think we can now get started. So, good afternoon, everyone, and welcome to our second session of the Knowledge Exchange webinar series of Bridging Health Systems, which will focus on the benefit package design organized by the Egypt Impact Lab at Japan MENA in collaboration with the Universal Health Insurance Authority and the World Health Organization in Egypt with our guest speaker, HITAP. Before we begin, I would like to inform you with a few housekeeping notes. Firstly, please note that this webinar is being recorded and the recording will be shared with the participants after the event. Also, this webinar is being held in English language with live interpretation available in Arabic. You can select your preferred language from the interpretation icon on your Zoom toolbar. Also, the session will run for approximately 90 minutes. And finally, please feel free to drop your questions in the Q&A box throughout the session. We will address them during the open discussion segment. Now, I'm delighted to hand it over to Dr. Riham, the director of the Egypt Impact Lab, who will be delivering our welcome remarks for today.
Thank you, Arwa. Good afternoon, everyone. It is a pleasure to see you all here today for the second session of the Knowledge Exchange webinar series, namely Bridging Health Systems. I would like to start by warmly thanking our colleagues from the Universal Health Insurance Authority, the WHO in Egypt, and JPAL Southeast Asia, as well as our partners at HITAP, and all of you for taking the time to join us. We truly value the commitment and the interest you have shown in building on an open space for cross-country learning and dialogue on Egypt's universal health insurance system. As many of you know, this webinar series was launched by the Egypt Impact Lab in collaboration with the UHIA and WHO as a platform for practical peer learning. The aim is to connect policymakers and technical experts in Egypt with counterparts from other countries who have grappled with similar challenges and have lessons to share. Our first session in April focused on benefit package design with valuable insights from Chile and reflections on Egypt's own experience. Today, we are excited to continue that conversation by looking more deeply in how health technology assessment, or HTA, can inform benefit package design, drawing on Thailand journey and practical lessons from our guest speaker at HITAP. This work is vital because evidence-informed design is at the heart of effective, equitable health systems, especially when countries are undertaking ambitious reforms like Egypt Universal Health Insurance System. Through the Egypt Impact Lab, we aim to generate rigorous local evidence that can inform policy implementation directly, but just as importantly, we aim to support what we call embedded evidence use, helping our partners build systems that enable real-time learning, feedback, and adaptation as program scale. Embedded labs like Egypt Impact Lab create a bridge between research and practice, working side by side with government institutions to identify priority questions, test solutions, and feed insights directly into the decision-making process. In doing so, we help ensure that the policies and programs our partners design are not only ambitious in scope, but are continuously improved and responsive to the needs of citizens on the ground. For example, with the Universal Health Insurance Authority, we are exploring how rigorous impact evaluations can shed the light on important design issues, such as the inclusion of informal workers, the role of private providers, or how providers' incentives can drive better outcomes for patients, and finally, patients' satisfaction with the health service. At the same time, through this webinar series and other policy dialogues, we want to bring in global evidence and experiences to help UHIA and other partners make informed decisions in areas where local data is still emerging or where comparative insights can offer fresh perspectives. Egypt's universal health insurance system is one of the country's largest social protection reforms indicates. It has the potential to ensure that every Egyptian can access high-quality, affordable health services without facing financial hardship by 2035. But achieving this vision requires solving complex challenges at every stage, from how to design a fair and financially sustainable benefit package to how to incentivize providers reach to underserved populations and maintain quality across diverse contexts. This is where the platforms like the Knowledge Exchange webinar series add real value. They help our partners tap into practical lessons, learn it elsewhere, adapt them to Egypt context, and connect with peers facing similar questions. They also foster a community of practice around evidence-informed policymaking, making the culture of continuous learning and adaptation part of how programs are delivered at scale. Before we begin today's session, I would like to highlight this is just one piece of our ongoing journey. Our next webinar will take place on October 1st and will focus on the inclusion of informal workers in health insurance, featuring lessons from Indonesia's experience with the JACAN program. And we look forward to seeing you all there and to continue this series together. I would like to express my sincere gratitude to our colleagues at JPAL Southeast Asia office, particularly Lisnawati, the Training and Policy Manager, and Lina Marliani, the Executive Director, for their exceptional leadership in advancing initiatives focused on evidence-based policymaking and for their continuous support to the Egypt Impact Lab. Finally, it's my great pleasure to introduce our guest speakers from the Health Intervention and Technology Assessment Program, HITAP in Thailand. HITAP is widely recognized as a leader in using health technology assessment to inform fair, cost-effective health policy decisions, and we are delighted to have them share their practical experiences today, which we hope will inspire and inform Egypt's own benefit package design process. With that, I will hand it over to our colleagues from HITAP, Sodomini Vishwans and Kinanti Kamsa. Thank you again for joining us, and I wish you all a fruitful session ahead. The floor is yours. Thank you very much.
Thank you so much, Dr. Reham, the JPAL team and WHO colleagues, and all of you here for joining this webinar today. We are really excited to share our experiences. Hope it's of some benefit to you, and that really it spurs a conversation for us to take forward beyond today as well. So perhaps to the next slide. Today we will share a bit. We'll start by sharing a little bit about what HTA is and how we see its role in achieving supporting universal health coverage. Talk a little bit about our experience, both in Thailand and internationally, in institutionalizing HTA, and then dive deeper into Thailand's experience, and then close off with some questions that we hope can feed our ensuing discussion. My colleague Kansa is on the right, and I'm Saudamini, as introduced by Dr. Reham earlier. Thank you, Kansa. So first off, in terms of what is health technology assessment or HTA and its role in universal health coverage support, One, we start with the premise that health resources are scarce. The picture here is drawn from the UK's experience. We have very limited, not only physical, but also financial and human resources, and we need to be able to distribute them amongst many people. And at the same time, what experience has shown us is that investing or putting in more money itself is not guaranteeing an answer. The data here might be a little dated, but the issue that it highlights is still relevant. The example or in the graph is that the United States, which spends the most amongst high-income countries on health, still sees less in terms of health outcomes as shown here in terms of life expectancy. And reports have shown consistently that much of the spending on healthcare remains inefficient, with only a fraction really being able to account for an impactful line towards health outcomes. So this is where we see health technology assessment, or sometimes called health intervention technology assessment, come in. It's a multidisciplinary approach. And one of its key points is that it uses explicit methods in order to inform decision making. And the cornerstones of this approach are that it promotes equitable, efficient, and high quality health system. And that really is what we are aiming for, using evidence that is multidisciplinary, explicit, and promoting these features. And in that, it supports the broader ambition that countries have committed to achieving. The Sustainable Development Goals have 17 goals. But as articulated by colleagues at WHO, health is really quite central to achieving them. And goal number 3.8, as some of us may know, is geared towards achieving universal health coverage. And that is oftentimes also translated into the UHC cube that you see on the right-hand side, which has 3 dimensions. And HTA could be one that could help define all 3 dimensions. Traditionally, it might be on the right-hand side on the service coverage, but it can also be used to identify who should be covered and also to what extent any benefit that is provided should be covered. So all 3 dimensions of the UHC cube. There's also, in addition to the broader commitments to UHC, we also see that countries have been able to articulate the role of HTA through resolutions at the World Health Assemblies as well. You see one at the regional level in Southeast Asia, but also 2014, we saw a WHA resolution for health intervention and technology assessment. And more recently this year, the role of HTA was identified in supporting domestic resource allocation, especially in the current climate. So emphasizing where we are today. So one thing we would like to highlight is that HTA is not merely a technical exercise. It's not only a cost effectiveness or cost utility analysis, but also is embedded within a broader process that starts with identifying a policy relevant topic that is then refined and addressed through evidence and goes through a process of review.
قدم من الأدلة، ثم بعد ذلك النشر، ثم الانتشار، أو ثم التنفيذ الخاص بالنظم الصحية. ويمكنني أن أشارككم أو أتشارك
with institutionalizing HTA. In terms of HITAP's own experience of HTA, we have been over time employing a 5-pronged approach, so to speak, to develop the HTA system. One is we realize we have to start somewhere and develop, not only doing in our organization, but also more broadly. The need for cost data, for example, even though it wasn't there when we first started doing HTA, we invested some time with other experts and learning from international experts to develop these kind of databases that can help and aid conducting HTA in the future. Building the key feature of doing any research, as you may be familiar, is the lack or need of human capacity. And one of the ways we've been doing that is really through on-the-job learning. So our staff get to be in the front row of doing policy relevant research and defending that in front of policy makers and decision makers as well. In addition, we've also been conducting trainings, and we are in the process now in more than 20 years in the running of an annual economic evaluation training in Thailand as well. So growing the pool of researchers who are conversant with HTA and economic evaluations. But really at the heart of it is the HTA research that is done, and importantly, that it is done for policy. So this is something that Khansa will share a little more about, how we go about ensuring that the work we do is really something that our counterparts are able to utilize. And that links us to the other part, that this knowledge management is really a key ingredient. Doing research without being able to communicate it with the constituents does not have the impact that we intend. So being able to publish in research, peer-reviewed journals, as well as develop policy briefs or other ways of communicating with our audiences is also a key part of our work. And finally, we really can't do this on our own. And so building and nurturing a network has been also one of the key things we've been striving to do since the start as well. And building off that idea of having a network, we also realize that we have a lot to learn from others as we learn, as we also try to develop ourselves. And primarily over the past now more than 15 years, we've been working with countries in Asia, but increasingly also in your part of the world, including with Egypt. We have had some conversations with colleagues here over the past couple of years as well, and we hope to be able to continue going forward. But coming back to Asia, where we'd like to share a few experiences, we'd like to note that each country is quite different. We have countries that have some of the largest populations in the world, as well as some of the smallest. We also have different terrains. We have island countries. We have the largest archipelago in Indonesia, but we also have landlocked countries that are unable to access land, and those that are really some very high-income countries, but some still trying to be able to go about their health systems and utilize the limited resources that they have. So HTA is operating within these very diverse contexts in the Asian region. And what we found is that it's really important to be able to use, again, a multi-level or multi-pronged approach when building or institutionalizing HTA as well. And we've used a UNDP approach called INNE, which is the individual, node, network, and environment. And the way we've interpreted this framework in our approach is one at the individual level to support on-the-job training, for example. At the node level, being able to have some kind of infrastructure that policymakers can use, and also HTA organizations and the relevant institutions are able to utilize in order to take forward any work related and have policy impact. But as mentioned, both at the national and international level, having networks within the HTA space has been something we find to be quite critical to share knowledge, to be able to tap on for information as well as otherwise. And then also be able to work beyond HTA. HTA is only one piece of the puzzle. We recognize that it is situated within the broader context of the health system, and then more largely within the economy and society. And increasingly, there's a demand to think about how multi-sectorality can play into this process too. And so that's why we also think about how we can engage with higher level policymakers too and other stakeholders. So very briefly to share, as mentioned in terms of on-the-job training, both in Thailand and internationally, we work jointly with counterparts, typically in HTA institutions in the ministries of health, but also sometimes other researchers who might be working on HTA as requested by the appointed HTA committee. Sometimes we have country-based trainings and workshops. I will move a little quickly just in terms of time. Increasingly, we are seeing that country-based workshops or country-based work could be quite atomistic. So we've tried to aggregate and work more at the regional level. So both in terms of trainings and workshops, as well as looking at other convenings. I will just move a little quickly on this, if you don't mind. Okay, all right. Sorry, I will maybe go back 1 second. Would like to highlight one particular piece of work that my colleague here, Kansa, did with others on developing guidance for guideline development. We know Egypt was one of the few countries we always look to for having a guideline on HTA. Now there are more that want to do something similar, and we found that having some guidance is helpful because there are a lot of commonalities. And again, one of the key recommendations that you see is also having a process in which this guideline development can be embedded within countries as well. So we are hoping such kind of guidance that is provided at national or regional level can be beneficial. This highlights again the need for having knowledge products, whether they are global or regional public goods, that can be utilized and translated at the national or subnational levels where HTA decisions are made, and the need for having knowledge exchange platforms, whether directly on HTA or on other related topics. And again, to highlight one network I'll just highlight here is HTA Share Link, which is a regional network that we have. There is no seed funding. Each organization brings its own resources and hosts an annual conference regularly to bring together early career researchers and give them a platform to share their work and also be able to build their network with others too. And one particular platform I'd like to highlight, another platform that I'd like to highlight beyond HTA is the Prince Mahidol Award Conference. Some of you might be familiar with it. In 2016, we hosted this on priority setting, and it helped really mobilize and catalyze some of the efforts in some our partner countries, whether it's Indonesia or also India, and pave the way forward for collaborations and also for HTA within those countries. And next year in January, this is just to share that the topic is going to be on demographic transitions. If you or colleagues are interested, please reach out to Kansa and we'll try to see how best to also engage with you through this conference, not only for those interested in HTA, but also more broadly on health. And again, to look at the environment level, we also recognize being associated with the Ministry of Public Health in Thailand, whom we work with closely. We also are able to engage more broadly. And one example has been in Kenya, where we signed an MOU and had a partnership that really helped facilitate the partnership and take forward the knowledge exchange and collaboration. And this is not to say that developing such processes doesn't come with challenges. We've also, whether it's financing, whether it's actually being able to link the research to policy or continuing to train technical capacity. But what we've learned is that there are ways we can overcome this in the short and the long run as well. And even though we also encounter many misinformations or misconceptions about HTA, which we think can be dispelled through communication and better awareness of what HTA entails. And finally, to then pass the baton to my colleague Kansa, we've over the past 10, 15 years of HITAPs, we've also learned through these processes from ourselves and would like to share a bit more about our work in Thailand.
Thank you, Soda. So before I start, perhaps I would like to give just a little bit of context about Thailand. It is a middle-income country with 17 million population, and our health expenditure is dominated by the public sector. And our road to achieve universal health coverage was not short and had insurmountable challenges. But with efforts from the society, political figures, and also science, Thailand adopted UHC in 2002. The UHC in Thailand comprised of 3 public health schemes covering all Thai population and dominated by the Universal Coverage Schemes, or what we call UCS. It covers 75% of the population and financed through general taxation. Thailand has also a national formulary, or what they call National List of Essential Medicines, where all 3 public health insurances reimburses drugs according to the list. So I would like to highlight here that HTA is not actually adopted by a single province in Thailand. So pharmaceutical products, there is a process that is housed under the Thai FDA, under the NLEM process, or National List of Essential Medicine process. And there's a separate process for non-pharmaceuticals and non-vaccine product, as well as a separate process for vaccines products and public policy evaluations. And some of our partners actually asked how to actually manage HTA processes if it's not centralized under one institution. So HTA is a collaborative process, and it takes some multidisciplines to contribute to the process itself. I would like to first highlight the role of the HTA agency here that serves in the fraction of very big working groups. So Health Economic Working Group is just one part of various working groups working within these different processes. And HTA agencies take a role of secretariat, which is very important as they have the technical capacity to be able to deliver and oversee some of the processes under the HTA processes. These working groups are then communicating evidence to the subcommittees, whether it's for the health benefit package committee or for the drug committee. And then these committees will make policy recommendations to the board that is chaired by high-level ranking positions. In the case of the universal coverage benefit package, it is chaired by the health minister. And for the medicine, it's chaired by the deputy prime minister. So I would like to also highlight that these processes, although they're separate, they adhere to the HTA guideline. And just to echo what Saudamini said earlier, that our recent study actually found that guidelines is a very important tool, and the process of developing the guideline is equally important. What we found is that actually the process itself of developing a guideline, it brings together different stakeholders to learn from and with each other to understand how they could contribute or improve HTA processes and building up usually from pre-existing processes. Okay, so now we're going to dive deeper into the benefit package design process in Thailand, specifically for non-pharmaceutical intervention. So in broad view, there are 4 main steps. First, we select topics from the topics that is nominated from different stakeholders. And then we assess these topics and also appraised by external reviewers. And the last step is decision-making that goes actually into multiple levels, which the final decision is taken by the National Health Security Board, chaired by the health minister. Okay. So in the topic nomination process, we invited 7 stakeholder groups, with each stakeholder group can nominate up to 5 topics. This we can ensure that there is enough balance from different groups to be able to voice what they deem important. Although we are through these stakeholder groups, we're trying to cover different topics that is important from different perspectives. Sometimes there are also topics that is overlooked, for example, health promotion, or topics that requires effective access to care. So we also consider to have these type of topics to be also included. From these topics that has been nominated, we prioritize explicitly using a criteria. So these 6 criteria is scored by the commission academic team, and about 10 to 12 topics will be proceeded further to the next step. So here, just sorry for the low quality of the image, but this is just a showcase. We have a predetermined scoring parameters. So for example, taking the example of criteria number 1 on the prevalence. So the higher people that have the disease, the higher score it gets. And so it should be on the top of the list. Okay, so these topics are then assessed through a very long process, which can take 6 to 8 months, depending on the types of assessments that is required. First, we conduct a stakeholder consultation, which is a very critical step in defining the research question and also the research scope. And then the proposals, and also in the stakeholder consultations, we consult how to get data inputs, especially for cost and cost parameters and other parameters that may not be directly available in the database. And then from the consultation, commission researchers are going to develop proposals, and then they conduct the study and they have to adhere to the HTA guidelines. The second stakeholder consultation, where the research teams present the preliminary result, and it will be taken for extra review and then making reports before presenting it to the working groups. And then these are just the example of some supporting research team in Thailand. It's, I think now they have grown into 26 institutions that can conduct HTA in the country. And then moving forward to decision-making process. So it's a multi-layer process, and from the, sorry, I just wanted to get back a little bit. So from step 7 here, where the presentations of the results from the working group is being shared to the subcommittees. The subcommittees then make policy recommendations. Usually they use these 5 criteria. There could be more, as I think the space is also evolving. And then the final decision is going to be taken by the National Health Security Board that has diverse group inside the board itself. So I think from our quick presentation, HTA seems to be very much associated with value for money or economic evaluation. But these policy decisions are just saying it is just part of the evidence that inform policies. So if you can see here, I want to take one example on dialysis. It is a very high cost intervention, but there is a disproportionate in access because only people who have more money could access the dialysis at the time. And it's clearly not cost effective and have high budget impact. I think based on this evidence alone, it does not seem logical to approve this kind of intervention. But I think throughout a very rigorous process, NHSO asked for endorsement and push it up to the parliament to get this intervention approved and get additional funding to the UHC for so they could include dialysis to the benefits package. So NHSO, or the payer for the benefits package for the UCS scheme, they also conduct some centralized procurement for some technologies. These are just some selected technologies to showcase how powerful the centralized procurement could help the payer to save costs. I think this paper is particularly interesting. I can share more the link to the rest of the group if you'd like to read the details of the strategy of the centralized procurement by NHSO, or the payer of the UCS. Okay, so I think I just want to also echo what Saudamini mentioned earlier, that these process that Thailand has, it's not a standalone process built domestically. I would like to also highlight the role of global and regional support, as HTA is an advancing area. There are new methodologies, new processes to make everything more efficient that is explored. And we're very much looking forward to always learn from our partners, country partners, and in this case, Egypt. And I would like to also invite everyone to perhaps, before I close this presentation, to sit and think of the questions that perhaps together we could reflect. So reflecting from your work, and how do you think HTA could support your vision or goals in achieving better health in Egypt? And also we acknowledge a common, I would say, challenges that our partners identified is that the pre-existing processes, and there's a lot of institutions, how we try to kind of like have a very quick or the first step that we have to move forward that can be used to initiate HTA in Egypt. And also building on those institutions that has different processes, how do we navigate together to take this initiative forward? And pretty much HITAP is interested to also have and continue these conversations together and to see Egypt to have or strengthen better to strengthen for better health decisions and eventually healthier population. So with this, I hand over to Reham. Thank you so much for having us today.
Thank you, Tisna. Thank you very much for this insightful presentation on the HTA system. You have myself actually a bunch of questions regarding your presentation, and thank you for the reflections. I think if we can leave the final slide deck, sharing the final slide deck, it might be actually a very good opportunity for the UHIA people that we have in the webinar to take it from here. The questions are really very to the point, very concise and to the point. I'm going to hand now the floor to my colleague Ahmed Khalifa. Ahmed Khalifa is the coordinator of the Universal Health Insurance System, and actually he's really very aware with all the details and the intervention that has been already implemented. And he's an economist at the WHO. Ahmed, you have the floor.
Well, thank you very much, everyone. First of all, of course, thanks Reham for this collaboration, and great thanks to both Saudi Mini and also Khansa for your very elaborate presentation. It's always a delight and a pleasure to be part of this webinar series. So a couple of points probably before we get into the Q&A part. And just to put everybody in context, particularly those who did not attend the first webinar. So when we designed this webinar series a while ago, and we asked Universal Health Insurance Authority to identify the key topics that they want to have country-to-country learning experience on. And they sent us a list of topics, but on top of that, it was the benefit package design process. And maybe that's why we had the plan to have 2 sessions on that, learning from different countries' experiences. In the first webinar, we had a couple of presentations. The first was from WHO side. And the key message in that presentation for those who did not see the recording or did not attend is that the benefit package process is much more than just a list of service, but it also includes the conditions of access, and more importantly, the underlying technical and legal aspects that can lead to health financing reform and to link the health financing system with the delivery of care. And then this was followed by presentation from UHIA, Universal Health Insurance Authority, from Dr. Ahmed Siam, to highlight the key progress and also the gaps in the system with regards to the topic on the benefit package design. And then in this last session, we had a very important presentation from the former Minister of Health in Chile, Dr. Emilio, who actually shared the Chilean experience on benefit design. And prominently, what has been mentioned as a key message is how the benefit package in Chile, and the guarantees to health services, they call it GES system, has been used to harmonize entitlements or access to care for all people in Chile, whether they are in the public system or in the private system. And they had like 4 key elements of guarantees, if you can recall: 1 on equal access, 1 on guaranteeing financial protection, 1 on quality of care, and the other is about timeliness. So everyone has guaranteed services within these 4 aspects. And he highlighted, of course, the other aspects with regards to legal framework in Chile. But I think today's presentation, our session, is of equal importance for a couple of reasons. One is that, you know, as we see from the presentation, Thailand is a middle-income country, probably at the upper bound of the economic class. It's an upper middle-income country. Egypt is a lower middle-income country, but still, it operates within a very resource-constrained setting. And the great achievement that they have done over the years, in one of your slides, you mentioned that by 2022, you achieved almost full coverage. But I think one of the key drives behind this great achievement is not just about spending more on health, but how to best utilize existing resources. And in your case, you highlighted the reliance or embedding health technology assessment as a key tool to achieve this goal. I think also from the presentation, what makes Thailand very specific in a good way is that the Thailand experience or the Thai experience is very explicit in terms of the governance and institutional structure for health technology assessment, as well as being explicit on the technicalities and methodological approach for using health technology assessment. So you have your system, you know, around 4 key main steps, as you mentioned. The topic nomination, you mentioned who is able to nominate interventions. This is a very important point. And then in doing so, you have also limit the nomination by probably 5 nominations per year, if I understand correctly. And overall, you select 12 out of these. These 12 are based on a very explicit criteria in a multi-criteria decision analysis that is very, in a quantitative manner, that is scored. All those in the session who works in a health technology assessment field in Egypt, probably I see some of the names familiar, would appreciate your work, especially on the MCDA with regards to the topic selection. And then also on the other step, on the assessment and appraisal, what is the criteria and who is doing what? And this is a very key point. And last, on the decision-making process and the multi-level of the decision-making, one committee to recommend, and then there's a final committee to take the decision on behalf of the covered population. And how this can also be very useful in informing decisions. And you mentioned a couple of examples on price negotiations, for example, where you had better offers and deals, not just based on volume discounts, but based on value assessments that you rigorously undertake in your case. Now let's come to the most important point, and before probably people can start thinking about questions and how to learn from your experience, and also bearing in mind what we have also learned from Chilean experience, and other people also in this group of attendees. I see some of the names who has also been exposed probably to other country experiences, like in NICE in the UK, for example. So without repeating any of what has been mentioned in the last session, where it shows the landscape of the Egyptian healthcare system, and it has new agencies evolving, leads to consolidation of some functions and fragmentation in others. I think what has been agreed by all of us is the first step is to learn specifically from Thailand experience, is that regardless of the number of institutions, we need to have a unified national health technology assessment process or appraisal process. And this has to be cross-cutting across all relevant institutes. In Egypt case, I would say there has been some progress from the webinar number 1 to webinar number 2. There are some updates from agencies like Unified Procurement Authority, where they have been trying to do the process flow for technology assessment process for pharmaceutical products. So the same as in your case, you have one track for pharmaceuticals, one track for vaccines, and one track for non-pharmaceutical, non-vaccine products, which is basically the package of services under the universal coverage scheme. So in Egypt, there has been also some of the efforts combining different entities, including Unified Procurement Authority, together with UHIA, together with the Ministry of Health, to try to sketch out a process for health technology assessment. So this is something that is appreciated and commendable, and we hope we can also support this process and learn from the Thai experience as well on how to operationalize some of the concepts. So at this stage, we are, I mean, the effort that has been done by the national entities is on the process flow, but under each component of this, we need to operationalize the concept. As you mentioned, and I like very much the presentation. I guess the presentation, it's okay to share with all colleagues. And it's also good that you have links to the reference materials. You gave an example, for example, on topic selection. And what criteria does it take to select? So in the case of number of population, the parameter is prevalence. In the case of severity, we need the change in quality adjusted life years, etc. So it's very specific, very parameterized and easy to replicate and contextualize in the concept in the case of Egypt. The second point is to have the process as transparent as possible. What's also has come very clear in Thailand experience is that you're very specific with exactly, for example, the board that takes the decision. What is the representation from different entities? This has to be explicit, and this has to be granted within a legal framework that can then enable link the HTA evidence into decisions later on. And also to speaking about one of the points on your reflection slide, and if you please, Khansa, if you can bring the slide on reflections again and share the screen. The one point on the low-hanging fruit, I think one of the points is that we need to show that health technology assessment is useful. You did that in your case by showing how it informed policies in some key interventions in your case. You mentioned the renal dialysis, you mentioned a couple of high-cost drugs and how health technology assessment has been useful in doing this. So I think this also is an important point. So after agreeing on a unified health technology assessment framework, we need to operationalize this concept with an SOPs or a guideline, which I know also some of the efforts has been already done in Egypt. And then we need to show how health technology assessment is useful. And finally is to have, to sustain the efforts towards health technology assessment by having the technical core of people that can undertake such assessments over the years. There has been some efforts here and there, and all agencies are trying to support in this. I would say now we have growing calibers, growing body of calibers who can take this forward, and we hope that technology assessment can be used as a tool to inform design of the benefit package, but also as part of the overall healthcare reform, as you mentioned, Saudi Mini, in your opening remarks. So I have a couple of questions, of course, but I will stop here and give the floor to any of the colleagues who wants to first ask questions. You can either text it, or you can raise your hand, and I'll give you the floor. So you can ask your question directly to the presenters. You can do so in Arabic or in English, however you like. I can kick off the discussion with one straightforward question. So this one I was preparing, and I want to ask, you highlighted this during your presentation, that the time it takes to reach a decision can take up to 8 months. And I know that it can take maybe more in some instances. So you said from 6 to 8 months when you have full health technology assessment needed. So at some point, this, especially when you do not have the full capacity, when it's a nascent process that we're trying to establish, there's the people, especially at the high level now, they're appreciating what health technology assessment can bring. But there is always the time pressure that there's a need to reach into a decision as soon as possible. So now there's a growing evidence about what's so-called adaptive HTA. You can call it rapid review, whatever it is. So I want to also understand from your experience about this point. Do you use or open to use adaptive HTA, or do you use evidence from other countries and contextualize to your setting? And under which conditions do you resort to this rapid review pathway? And the other point is that the process you have shown us, I think it is relevant to the universal coverage scheme package. So may I also ask you to highlight what about the national list of essential medicine? Is it like the identical process but with different stakeholders, or what exactly are the changes? Thank you.
Thank you so much, Ahmad, for your first reflections and also these questions. So maybe just to start, one on the timeline, yes, that is always a big of conducting such a study, like an economic evaluation, a full economic evaluation. It does take time. And sometimes it goes through multiple reviews and changes, and sometimes it can go up to a few years even that you have a decision for a study. So there is it does happen, to say that. In terms of what has been the consequence, especially during COVID, where there was a big push for getting evidence for some interventions that were required for emergency purposes. There were rapid reviews that were conducted, and for the first time, we had a more formal, explicit presentation of rapid reviews for this UCBP process that Khansa mentioned. There are also now some criteria when we would use rapid reviews. So in the case of emergencies, we might consider having rapid reviews. But as such, right now in Thailand, we do not endorse using adaptive HTA in a formal way. That said, there are similar pressures for other countries in our region, and we do find that they are also looking at these topics of adaptive HTA. And what that means by adaptive HTA also varies. So whether it is only rapid reviews or whether it is using cost data from another country and using some method to translate it domestically or something else, that definition varies as well. But we do see in our region that more and more countries are looking to see how to overcome this challenge of growing demand for HTA or economic evaluations and the limited capacity to be able to address it within a certain time. So this is something that is ongoing. But just to reflect on your point that this is, we aren't yet formally in the adaptive HTA wagon. But we are seeing that we do need to find different ways to approach different decision problems and different evidence needs that might accompany them. Anything to add on the timeline part before NLEM, Khansa?
I think I just wanted to echo that currently rapid adaptive HTA is not formally embedded in any of the HTA process in Thailand. And I think there are quite some limitations regarding the methods. And we are actually also exploring to some extent how this rapid HTA, whether it is rigorous, what kind of method that is rigorous enough if we were to adopt adaptive HTA. So we're still on the space of exploration and not yet embedded it into the form process. But I think I just wanted to also highlight there is always policymakers always push for quicker decisions. Although I think in some cases they always pushes the research team to make evidence or generate evidence quicker. But I think the finding the balance of having the rigorousness of the method and also providing with policy recommendation should be find. So I think that's for the rapid review. And I think if we want to continue conversations on this topic, we would be more than happy because this is also a growing topic that our partners are looking forward to.
And to your second point, Ahmad, talking about the National List of Essential Medicines, so I'll just start and Kansa can add. It's a feature, as Kansa mentioned, of our health system that we have these two different tracks. But it is not something necessarily that is recommended. If you have one track option, it might be more efficient as well. But as Kansa mentioned, the National List of Essential Medicines, it covers all the 3 public health insurance schemes in Thailand, meaning it covers what is in the list, covers the entire Thai population. And second is that this is an optimal list of essential medicines. It's not a minimal list, but it is a comprehensive list that should be made available. And that's why we have different categories of medicines in this list. I think there are about 800 active ingredients that are included. And only one category, it's called the E2 category, the high cost medicines. It's only for that group that we conduct economic evaluations. And this process is also quite different from the one that Kansa shared. You may notice that the UCBP process, that the non-pharmaceutical benefits package, is quite participatory. It involves different stakeholders and covers a range of different interventions. With the NLEM, it's far more focused on technical experts and clinical experts. Of course, there are inputs from different groups. It follows the same HTA process as well. But it does derive a lot more on the clinical experience in the country primarily. And the process as well otherwise is quite standardized in terms of how the research is conducted. And one of the other key features that Kansa mentioned here for non-pharmaceutical benefits package, but in the case of NLEM, it's done across, again, the 3 schemes. So 70 million population. Of course, it varies by the size of the population for each condition. But we have a price negotiation working group as well that uses the results of the economic evaluation to negotiate with manufacturers. And this has, as Kansa showed more generally with centralized procurement, we found that economic evaluation analyses and threshold analyses that show what can happen if we change the price actually has helped provide hard savings in cash for the government when it has come to medicine. And as you may be aware, in many countries, medicines account for a majority of the costs in terms of health expenditure. So this is quite sizable as well when it comes to medicines. The other point just to mention is that until fairly recently, the vaccines used to be part of the National List of Medicines. But recently, given some specific considerations or concerns, there is a distinct track, so to speak, as you called it, for vaccines within that NLEM, as Kansa is showing on the screen. So right now, yes, there is a National List of Essential Vaccines as well. But in the past, it used to be part of the same essential medicines list too. And before just turning it to Kansa, one comment just to make to Ahmad's point that yes, Thailand is an upper middle income country now. But when we started on universal health coverage and when we started first using HTA, after HITAP was set up, one of the first, our low-hanging fruit was the National List of Essential Medicines. We were able to get this E2 category and utilize economic evaluation. And we were still a lower middle income country at that time. So we really do think that, in fact, when we have lower resources, it's even more important to be able to utilize them in a rational manner. And that really makes the case for HTA as well. So with that, Kansa, anything you'd like to add on the NLEM or medicines side?
Yeah, I think generally the 4 steps process still applies, but I think the details, there are, I would say, back and forth between the working groups, and there are different working groups also that Sarah has mentioned, different experts involved. But the principles between the HTA processes here that I'm showing on the screen is similar. So I think at that, when you ask if it's similar, it is, but the level of the timeline needed and then people involved in the process and perhaps the details in the process is quite different, as it has intrinsic characteristics of assessing drugs and non-drugs. It's there's some distinction in that. So that's my point. And I think I would like to also highlight what Sadhuri mentioned about making a case, because evidently, I think how HTA is getting onboarded in our partner countries is by showing proof of concept, whether it's through the assessment itself or the development of the guideline. But it seems that this approach seems to work in quite some countries that we have worked with.
Thank you very much for this, detailed answer and response. Now, can I ask participants for any other questions and reflections?
Ahmed, can I jump
Yeah,
in
sure,
before opening the discussion?
Yeah.
Before opening the Q&A, we do have Ahmed Siom. He is the Deputy Executive Director of the Universal Health Insurance Authority, and I think he might have some reflections and answers or questions to the HITAP folks. So I'm going to give the floor for Dr. Ahmed. Please, it's over to you. Dr. Ahmed, are you with us? I think Ahmed, Dr. Khalifa, I think in Ahmed we lose Dr. Ahmed.
Maybe he joined.
Whenever he joined, we
yeah.
can give
He's
him
on the
floor.
line.
Okay,
He's on the line.
Yes. Okay, so maybe when it's possible, just let us know, and of course he will take the floor for sure. But Shiham, do you have a question specific you would like to ask to HITAP colleagues or anyone from the floor? Of course, we booked your calendar until 1:30, but it's okay to finish earlier. But but we still maybe have 1 or 2 reflections and questions.
I do have a question for the HITAP people. Thank you very much for the insightful presentations. Again, one of the points that you have raised, which is really very interesting to me, we are trying to do the same. But for the whole program, not only for the benefit package, is the idea of the stakeholder consultation. So you mentioned that during this stakeholder consultation, you gather priorities and data inputs and stuff like this, which is, again, my question to you is what kind of data that you gather, or the HTA database, how it looks like actually, and how later on you use it to inform the decision-making process. This is the first question. The second question is related to the pillars where the HTA centered, which is cost effectiveness, budget impact analysis, and feasibility. I really want to hear more from you about the budget impact analysis and how this idea actually embedded in the universal health insurance, because this is something of an interest and importance to our colleagues in Egypt. And finally, this is a very generic question for you. What kind of challenges that you encounter in order to embed the HTA and the health system in Thai, and how we can actually benefit from the lessons that you learned during the way in order to embed this and to do such an impressive accomplishment? Thank you. Sorry for the much questions that I threw for the floor.
Thank you so much, Dr. Reham. Maybe we'll go question by question, if that's okay. So first, around the stakeholder consultations, it depends on where we are talking about involving stakeholders. Typically at almost each step of the process of HTA, we try to engage stakeholders. One is at the first step that Kansa showed is when we are trying to prioritize from the large list of questions that people might have. So the government so Ministry of Public Health might have some priorities. Department of Health within that might have some priorities, but Department of Mental Health might have some priorities. So what we try to do is to open it up to all these different stakeholders and say, like, what do you want to be able to be included in the non-pharmaceutical benefits package? But because, again, resources are limited, so we try now to have, over time, this has developed a bit further. So we've tried to group different stakeholders. So there are specific groups that are invited from these 7 groups that Hansa mentioned at the topic nomination stage. So that's the first step where they get to nominate topics. And they get to ask like which ones they would like to be included. And we've sort of had a quota now, as she mentioned. So there's only 5 per group, so that no one group dominates another as well. You may also wonder then, so now as the next step comes, this is where we try to prioritize based on evidence that Ahmad also called MCDA, that where we try to use a very quantitative approach, and we also try to synthesize the evidence and be able to then justify why we are selecting these topics before going forward in the process of assessment. Now, when it comes to the assessment stage as well, what Kansa also shared is that we engage stakeholders in a more focused manner for the study that is being conducted. So we develop a proposal. Once the topic has been identified as a priority for the current cycle, then we develop a proposal and then have a consultation with relevant stakeholders for that particular topic to get their input so that we are able to hit the hammer on the nail and get the right research question, not just the policy question. And this is one thing that we often get, right? People want to know, like, how much does something cost? Or I want to get this intervention included. But when we have to convert it into a research question, we need to look at the intervention, we need to look at the comparator. And this is where the stakeholder consultation helps us, because sometimes different stakeholders will know better what they want to get from the inclusion in a benefits package as well. Plus, as Kansa mentioned, the data inputs that we may not already have access to. Initially, when HITAP first started, we used to borrow data, to Emma's point as well, from other countries, whether it was, especially clinical data is relatively easy to borrow, but cost data, typically we need to use domestic data. So one of the investments we made early on is to create this cost database. So we did a survey to collect data on costs, and we included the typical costs that we might need to conduct an economic evaluation. And we used that one, we adjusted for inflation, and now we input it into our economic evaluation. There might be some costs that may not be included, which might be specific to the condition, in which case primary data collection might be required. And in some cases, it might not be publicly available. So in that case, so for example, the price of a certain new intervention that is not in the market, we might need to get that information in confidence, perhaps, from the private sector as well. So that is where engaging with stakeholders in this assessment phase of the study becomes also quite important. And then once the study itself is conducted, we again come back not at the end, but right before the end, to get their inputs that, hey, this is what we found so far. Does this make sense to you? Do you see any major issues, or do you agree or disagree? Or where this helps also identify blind spots, sometimes also can help validate the process before it is sent forward for further appraisal and review as well. So this is that subset of the assessment only, where we include stakeholders for that study. And then it goes through the process for review and appraisal, which we in Thailand have sort of combined as well. And where the decision then is made the recommendation is made by the subcommittee that Kansa mentioned before it goes to that high-level decision-making authority that then will endorse and approve it. In the case of the the non-pharmaceutical benefits package, as you saw, because that board is set up by law, so that's why it's also quite clear-cut, as you remarked earlier, Ahmad. For the NLEM, it is for all 3 insurance schemes. So they have representatives, again, from all the different groups that are relevant for managing those different schemes as well. So again, here you will see that there is an engagement with stakeholders too. So anything on the stakeholder point?
Yeah, I think on the data collection, on the first stakeholder consultation within the assessment part, I just wanted to highlight the types of data that we gathered. So I just wanted to make an example. Currently, we're doing a economic evaluation for screening, for newborn screening, and we had stakeholder consultation. We asked the type of patients that we should include, where we could engage and how we could engage with them, considering that it's a rare conditions that we're evaluating. So those type of questions, if it includes primary data collection, would be asked with these experts. And also the HTA database that you mentioned, we currently only have standard costing list, but I wanted to mention one of the regional effort by HTA Asia Link is also to have HTA database, results from HTA countries or members of HTA Asia Link. I think this HTA database is quite unique, and it will include reports as well, so we can see all countries' results or HTA recommendation, and it will be launched next month in August. So yeah, I think this is also something that perhaps worth noting as for our regional effort. Another point on stakeholder consultation, I wanted to kind of highlight what Sara mentioned about cost data. I think this is also one unique characteristic in Thai HTA design is that, especially for submissions or topics nominated by health industry, we ask them to share with us how much or what would be the price point that we should assess. So instead of, I think a lot of countries, they receive submission of HTA studies conducted by private, but in Thailand, because it is not, we do not accept such studies, but for topics that are nominated by them and got through until assessment part, we ask them to share what is the price that we should be included in the study. And I think this is also gives a little bit of advantage of the payers, in a sense that I think from what we have shared experiences at HITAP, we got some discounts before even got into the price negotiation, because they would think the market price may not be suitable considering the volume. And especially on that phase, the first stakeholder consultation, they do not know yet how much is the volume or how the model will be constructed. So this kind of I would sometimes say, give us a little bit of advantage, perhaps. So yeah. Maybe continue to the second question.
Yeah, I think this is actually a very interesting point, and hopefully as the conversation unfolds around the role of the private sector, and I'm jumping to your last question a little bit before the second, but one of the increasing, maybe not pressures, but at least interest is how we engage with the private sector too. Right now, we are able to do what Khansa also mentions, because we really are able to keep quite an arm's distance between the HTA agency and the private sector in Thailand, especially. Increasingly, there is an interest to engage the private sector in different ways, whether it's through submissions. In Thailand right now, we don't accept industry submissions, but other countries in our region do, because there isn't enough capacity, also to the earlier point. And so that requires a different set of skills. But that also then means that we need to rethink how we can retain that degree of independence, and also the negotiating power that is there in the system. So this is one of the issues going forward that we may need to contend with as well. And one of the ways that we are trying to do to work with the private sector is through early health technology assessments, where we work with pharmaceuticals or other manufacturers to work at the design stage. So even before product comes to market, to see how they can design their products in a way that they can be cost effective when they are in the market and can align with the interests and requirements of the public payer as well. So this is one of the mechanisms that one of our new units, MIDAS, is also working on. But yeah, this is a space that we think we will also grow. I know you asked about budget impact itself. This is to address the issue of affordability. And that's why it's part of, Khansa mentioned the guidelines. So we do have to conduct an economic evaluation as well as a budget impact analysis, so that when it goes to those who are reviewing the evidence, they are able to see both its cost effectiveness as well as the budget impact as well. So there is a guidance for that. And there are some standards as well globally available for doing such analyses that can inform decisions too. And this can, Khansa mentioned it as one of the different criteria at the decision-making stage too. So sometimes something might not be cost effective, but if the budget impact can be somehow managed through cost sharing mechanism, for example, then it might still be included in the benefits package as well. So this is where one of the differences as well in Thailand to note is that we use MCD at the topic nomination and selection stage, but we do not use it at the decision-making stage. We don't think that we see the value in giving the decision-making body the right to utilize evidence to the extent that they can, because they are accountable to higher authorities and they need to take different evidence and different considerations into account, whether it's budget, whether it's equity, or whether there are other considerations. The dialysis example that Khansa gave is quite instructive. Because dialysis was not included in the benefits package when the universal coverage scheme was launched. And there was a lot of pushback from civil society to say, how can you say we have universal health coverage when a life-threatening disease like that, like end-stage renal disease, is not being covered? So they did make the decision to include it, as Khansa said, but the decision was informed by the evidence of an economic evaluation that showed that a certain peritoneal dialysis option could be relatively more cost-effective, and that helped redesign the system as well. And if we have a chance to talk again, we can go into more detail because we have more recent examples to share on this front too. I'm conscious of the time, so maybe I'll just hand over to Khansa to share if there are any other major challenges that we might have at the moment.
So I think just a very quick point on the third point of challenges. I think reflecting, because we work with several countries, reflecting on if we want to institutionalize HTA, I think a lot of countries are struggling to have the proof of concept. And this is also the problem of one of the countries that we're working with, which they have actually adopted HTA for quite some time, but the HTA system are actually challenged. I think one commonalities that I see is that we should be able to know what the government or what are the health system values the most to be able to give this proof of concept. For example, are we actually aiming for saving costs? Are we aiming for the speed of like, okay, let's have a lot of new interventions and make them more accessible? I know that I think health system try to be efficient and achieve all these goals, but I think for especially those who are taking the first step, having this proof of concept that actually provides the value of what they see from HTA would be important. If, say, a lot of stakeholders are actually valuing cost savings, then maybe there should be a case where you're doing a very good negotiation using HTA evidence and they're happy with it. And then wow, this is great. Maybe then we can advance HTA using that entrance. Or if the point is about giving access towards new intervention, high technologies, then perhaps we could think of adaptive HTA. I just wanted to be open-minded here of different ways that we could embed HTA. The entrance point perhaps could be different from different countries depending on what they value. But I think along the way, we can advance HTA into something that is more legitimate, that is efficient, and achieve a lot of goals in the health system. Over. Thank you.
Right. Thank you very much. We've received one question. I think it's an important question that says that in HTA we use cost effectiveness analysis and we use budget impact analysis, but in Thailand you're also adding another dimension, perhaps a couple of dimensions, but the question is asking specifically on the feasibility. So the question is exactly how you operationalize this concept in a way that is useful to inform decision rather than to confuse the decision makers. But I would like to ask you to respond probably in 2 minutes because we have about to finish. Yeah.
Okay. I can start very briefly. So I know Dr. Reham also mentioned this comment about feasibility. So one is it depends on the research question again. What is it that we are trying to answer? In some cases, for example, getting hearing aids, this was a topic that came through the channel that Kansa mentioned. They wanted to include hearing aids into the benefits package. But the first step, or even PET-CT, for example, that is a recent one as well, where they're doing a feasibility study rather than a cost effectiveness one. Because what they want to see is like, even if we do introduce this into the system, how will it benefit people as well? So sometimes it might involve doing a survey of the relevant groups, speaking to providers, speaking to patients as well to understand what they need. And sometimes as part of the stakeholder consultation process itself, they will try to unpack what are some of the considerations and whether including this or not including this intervention could actually have an impact on the benefits package or access to better health outcomes. There are a few examples on this, and in some cases, we have done an economic evaluation to assess the feasibility, for example, of screening for refractor eye errors among school children by teachers, because that could make it more accessible as an intervention as well. But we can share this perhaps later, given the time. But this is perhaps, and it also speaks to what Kansa mentioned in terms of using different types of evidence to be able to address the decision problem at hand. We'll pause and hand it to you for now, just given the time, if that's okay.
Well, thank you very much for the, not just for the presentation, but actually for the discussion part. It's very engaging, and thank you for all the details that you've shared. I think it's very relevant, especially to the context of Egypt. Just to mention that also in WHO there is one well-known report on health technology assessment that a couple of years ago on how to institutionalize health technology assessment. And I think many of the lessons that has been used in this report was drawing on the experience from Thailand in many ways. So we really do appreciate the work that you've been doing in your institution. I'd like to thank you. I'd like to thank Reham and the JPAL team and all the participants. I think also to mention that the session will be recorded, is recorded, sorry. So we will share the recording with those who did not attend or registered but couldn't be able to attend. And inshallah, next session for us would be on a slightly different topic, which is around the inclusion of the informal sector and featuring also the experience from Indonesia. And hopefully this will be, inshallah, during the month of October. So very big thank you to everyone, and see you soon, inshallah. Thank you.